Welcome to the Radiology Vault, an open repository for radiology educational content designed for learners and medical professionals. Presented by the Michigan Medicine Department of Radiology.
Hello, my name is David Bloom, and I am a pediatric radiologist at CS Mott Children's Hospital in Ann Arbor, Michigan. And it is my pleasure to speak to you today about a topic I find very interesting, sometimes confusing and stress-inducing, but I think we can make it as easy as possible for all of you, and that is neonatal distal bowel obstruction. I do not have any disclosures. In neonatal bowel obstruction, one easy way to try and sort out your diagnosis and how you're going to approach the patient is by thinking about the obstruction as either a high bowel obstruction or low bowel obstruction. Now, what do I mean by that? In a high bowel obstruction, on a recent abdominal radiograph, you should see only 1, 2, 3, maybe a fourth loop of dilated bowel. Now, you have to include a distended stomach, but however, the stomach may be decompressed by an NG tube. So if you see an NG tube in place, then consider the stomach also distended. With low bowel obstruction, there are too many loops to count. You try and count, and it's just too much overlap, too many loops. And so now you're thinking about a low or distal bowel obstruction. If you think you're somewhere in between, usually consider that a low bowel obstruction, which is going to dictate what you do next for the patient, but you may have to also take a look at the upper gastrointestinal tract. Now, what are the keys to neonatal GI obstruction? I cannot emphasize enough the importance of a recent abdominal radiographic study, and that is going to help you look at the gas pattern and differentiate between high and low GI obstruction. Also keep in mind, you will be given a clinical history where it may include bilious emesis. Now, any obstruction distal to the ampulla of Vater can cause bilious vomiting. So keep in mind that a patient with imperforate anus or a very distal Hirschsprung disease may very well have bilious vomiting, even though we use that as a key to thinking about malrotation and midgut volvulus. So always remember that bilious vomiting is an important historical concept that you need to know about, but it still may relate to a more distal bowel obstruction. Now, when we look at high or proximal obstructions, we're going to usually do an upper GI examination, or you may not need any imaging besides the radiographs in, for example, duodenal atresia, where you'll see a classic double bubble. But in high obstruction, we'll often do an upper GI examination, and we're looking for the entities listed on the slide in front of you. Most important, midgut malrotation with volvulus. Now, it also includes duodenal obstructions such as stenosis or, as I mentioned, duodenal atresia, and proximal jejunal atresia. Other obstructions can occur, such as annular pancreas with duodenal stenosis, or a mass or cyst might lead to a high obstruction. In the topic that we're going to discuss today, the distal or low bowel obstruction, our first step after the radiographs will be a contrast enema. I will not talk today about the specific choices of contrast, except to briefly mention that in most cases, water-soluble contrast is the preferential choice. Now, in low obstruction, our big four that we want to look for are Hirschsprung disease, meconium ileus, the meconium plug syndrome, also referred to as the small left colon syndrome, and ileal atresia, with occasionally a colonic atresia also a possibility. Let's take a moment to talk about the concept of what is meconium. We hear this term all the time in newborns about whether or not they've passed meconium in an appropriate time frame, whether or not there was meconium aspiration. That is a different topic altogether. But meconium is simply the contents of the intestinal tract in utero, and it's the first bowel movement. Now, it's important to understand the differences between the terms that include the word meconium, as you see listed there. I think it's better defined in the next slide. Simply to state that they are not equivalent, these different phrases or words. And so meconium is not the same as meconium plug or meconium plug syndrome or meconium ileus. Meconium is a normal finding. If there is passage of meconium within the first 24 to 48 hours, that's considered normal. A meconium plug is a plug of thickened meconium within the small bowel or colon, and it is a marker that something is not right, but it is not a diagnosis. Meconium plug syndrome, or the small left colon syndrome, is a diagnostic entity, and we'll talk about this in a little bit. And then meconium ileus, the same thing, a different diagnosis. It does have meconium plugs within it, but it is a different entity altogether. So keep that in mind. When you hear the term meconium or meconium plug, it is telling you that something might be wrong, but it's not diagnostic. Now, another term you need to be familiar with is the microcolon. The microcolon, or a very small appearing colon, results from failure of succus entericus, which is the in utero bowel content, to pass through the distal intestinal tract. Secretions, swallowed amniotic fluid, these are the things that are going to make up the succus, and that's going to pass through the GI tract in utero. This allows for the GI tract to develop normally. The microcolon will result if that process does not occur. So, for example, let's say a patient has a proximal jejunal atresia. On the radiograph, you would see what is sometimes referred to as the triple bubble instead of the double bubble of duodenal atresia. If the obstruction is high enough, and it is the only obstruction, then there should be enough succus entericus created in the remainder of the small bowel to pass through the colon so that you should not have a microcolon. If in that patient you did do a contrast enema and you found a microcolon, it would imply that there is at least one more distal obstruction, if not many. In a case I had as a fellow, I had a patient with proximal jejunal atresia. The enema showed a microcolon, and at surgery, not only was there jejunal atresia and a distal ileal atresia, creating the microcolon, but 6 atresias in between. Those you would never be able to find, but again, keep in mind that a microcolon implies a distal obstruction. Now, when you do the contrast enema, in general, you use a small end-hole catheter, and as I mentioned before, for the most part, you would use water-soluble contrast. When you do that enema, if the enema, in your opinion, looks normal, it may very well be normal and the patient does not have a mechanical obstruction or functional obstruction of some kind. The differential diagnosis does include Hirschsprung disease, as in a small percentage of cases, the enema can look normal and the patient still have Hirschsprung disease. If you see a small left colon, it is going to likely be the small left colon syndrome, although there is a differential for the possibility of Hirschsprung disease. If you find a microcolon, the differential diagnosis includes meconium ileus, ileal atresia, and the rarer total colonic Hirschsprung disease. I won't speak about that entity today, but concentrate mostly on meconium ileus and ileal atresia. If you find that microcolon, since we have a differential, you must try and reflux the terminal ileum, as you will see in the next few slides, to try and diagnose either the meconium ileus or the ileal atresia. Let us first discuss Hirschsprung disease. In Hirschsprung disease, embryologically, this results from a failure of migration of neural crest-derived cells, known as ganglion cells, to reach the most distal part of the colon. This results in a functional obstruction where the aganglionic segment does not allow normal relaxation, and again, we have a functional obstruction. There can be superimposed enterocolitis, although this is not usually seen in neonates since there is no time in the neonatal period to really develop a superimposed infection. Now, the enema is done with a small end-hole catheter and, as I mentioned before, typically water-soluble contrast material. What we're looking for on the contrast enema is a transition zone. In other words, the proximal innervated colon, the one that has normal ganglion cells, will be dilated, and the more distal aganglionic segment of non-innervated colon will be narrowed. Typically, the rectum should be more distensible than the sigmoid colon, such that the rectosigmoid ratio is greater than 1. In the case of Hirschsprung disease, because of the narrowed aganglionic segment for the rectum, the ratio will be reversed and less than 1. You may also see abnormal sort of sawtooth appearing contractions of the aganglionic segment. Now, the associations between Hirschsprung disease include trisomy 21, and for unknown reasons, it is very rare in premature infants. Now, the enema that you perform for the distal bowel obstruction and you're looking for possible Hirschsprung disease may be falsely negative. This is the case when there is something called ultra-short segment Hirschsprung disease. The aganglionic segment is so small and distal, it may be hard to see on a routine enema. These patients may present later in life with chronic constipation, possibly enterocolitis. Now, keep in mind that in a patient where you perform the enema and you think it looks normal, if that patient doesn't show clinical improvement, they may still need to do a suction rectal biopsy to look for Hirschsprung disease, where the enema may have been normal in that particular case. So, for example, we're looking at a newborn here who's undergone a contrast enema, and on the images, we can see a narrowed rectum, a more dilated sigmoid colon, and on the lateral view, which is on your left, we can see the sawtooth contractions of the aganglionic rectum. Another patient with too many loops to count. We see dilated loops on the abdominal radiograph, but also a few air-filled loops sort of interspersed, so too many to count. If you look at the middle image, we can see dilated small bowel as well. And those are the air-filled loops of bowel that are anteriorly located. The arrows are pointing to the transition zone with the associated abnormal rectosigmoid ratio. Again, there is some spasm of the rectum, the aganglionic segment. In another patient, very dilated loops of bowel on the abdominal radiograph on your left, filled with debris, that'll probably be retained meconium, and on the lateral view of the contrast enema, we can see a narrowed rectum and a transition zone to more dilated sigmoid colon indicated by the arrow. So that is what you'd be looking for with Hirschsprung disease. Here are my references, and I thank you for your attention.